a big question in revascularization, surgical or percutaneous. In the last decade, advances in technology have granted PCI more and more on the surgical classic territories. But what does the real evidence say on choosing CABG versus PCI? Let's see what the new ACC AHA guidelines have to tell us. Hello and welcome to the second episode on ACC AHA guidelines on coronary revascularization. In the previous episode, we discussed the indications of revascularization in different clinical situations. In this episode, we'll discuss how to choose between PCI and CABG. I'm Hussein Heshmet, I'm an interventional cardiologist, and welcome to my podcast. Generally, there are three factors that guide our decision for revascularization, surgical or percutaneous. Number one, patient's values. Number two, clinical presentation. And number three, coronary anatomy. Let's start by the first variable, the patient himself. The patient himself should share in decision making. In the shared decision making, strongly endorsed and highlighted in the guidelines, patients are given options and are allowed to negotiate and finally choose what fits their values and their preferences. Cognitive function, frailty, and life expectancy also drift our decisions. In many situations, these factors dictate a choice, which may not be essentially the best evidence-based treatment. For example, many patients choose PCI even when they are told that CABG has a better long-term outcome. On the other hand, several patients are turned down by surgery because of their frailty or limited life expectancy. Of course, when the question arises of PCI versus CABG, a heart team must function in. The team should have a cardiologist, an interventionist, and a surgeon, with possible members from anesthesia, medicine, and nursing, and other disciplines. The concept of heart team is highlighted strongly in the guidelines and gets a Class 1 recommendation. The second variable is the clinical situation. In ST elevation MI, CABG is associated with significant risk, and therefore it comes after PCI. Surgery is Class 2A only when PCI is not feasible, and when there is a large area of myocardium at risk. These are two conditions, not just one. We have to keep in mind that CABG will not improve myocardial perfusion in states of distal embolization and noriflow, which are very common in ST elevation myocardial infarction. So, in ST elevation myocardial infarction, PCI gets the upper hand. The third variable, of course, is coronary anatomy. In single vessel disease, of course, PCI is the clear winner. Other than that, the decision gets tricky. And let's start here by left main. In left main disease, significant left main disease, CABG gets Class 1A. And PCI is only Class 2A, only if it can provide equivalent revascularization to that possible with CABG. For multivessel disease, again, the heart team approach is essential. The decision is usually dictated in multivessel disease by the feasibility of either approaches. If both PCI and CABG are feasible, they get equal recommendation if the ejection fraction is more than 50. Whereas in lower EF values, CABG wins, is Class 1A if the ejection fraction is less than 35, and is Class 2A if the ejection fraction is between 35 and 50%. Patients with left main disease and multivessel disease with complex or diffuse disease and syntax score more than 33, CABG wins. CABG here is Class 1, and it improves survival. Even without left main disease, but with complex diffuse disease and syntax score high more than 33, CABG still wins. It also improves survival compared to PCI. This recommendation is largely based on the syntax trial. The trial reported similar mortality rates between CABG and PCI in the overall group of patients. However, extended follow-up of the syntax trial found a 40% higher mortality rate with PCI in the group of patients with multivessel disease. Okay, how about diabetes? We know that diabetes is associated with increased mortality risk from heart disease, more aggressive atherosclerosis, more extensive disease, higher mortality rate, and greater need for repeat revascularization. The guidelines recommend CABG rather than PCI to reduce mortality in patients with multivessel disease, diabetes, including a proximal LAD. CABG here is class 1A. PCI comes next, it's class 2A in those patients who have multivessel disease who are poor surgical candidates. PCI is even further downgraded, it's class 2B when there's left main and the syntax score more than 33. These recommendations downgrading PCI in multivessel disease and diabetes are based on several trials that showed higher all-cause mortality in the multivessel diabetic PCI group. So these guidelines up till now seem like balanced and reasonable. However, the surgical community was not very happy about it. The American Association for Thoracic Surgery and the Society of Thoracic Surgeons both had been involved in the guideline drafting process for 3 years, but they declined to endorse the final recommendations. They listed 3 areas of concern in their statement. The surgeons were angry because CABG was downgraded from class 1 to class 2B for improving survival compared to medical therapy in 3-vessel disease and normal ejection fraction. This recommendation was largely based on the ischemia trial. They were even more displeased with downgrading CABG from class 1 to class 2A to improve survival in 3-vessel disease and mild to moderate LV dysfunction. Surgeons were again irritated by seeing both PCI and CABG getting equal recommendation 2B for improving mortality in multivessel disease with a normal ejection fraction, even with proximal LAD. Surgeons were annoyed to the extent that the American Association for Thoracic Surgery, the Society of Thoracic Surgeons, combined with the European Association for Cardiothoracic Surgery, issued statements denouncing the guidelines and refusing to endorse it. How will this dispute unfold in the future remains something to watch, and we'll keep you posted. How will the guidelines reflect reimbursement of CABG as class 2B in multivessel disease with normal ejection fraction? How will recent trials like FAME3, where PCI failed to be even non-inferior to CABG, will affect the practice? These are all unanswered questions. I hope you enjoyed this episode. If you like the content, please follow us on Spotify and on Apple Podcasts, and stay tuned for the next episode. See you.